I'm going to talk about chronic cough. I'm going to talk about those patients, your loved ones, your friends, who particularly are adults, who are throat clearing and coughing. And despite everything you've tried, they're still coughing. At the end of this half hour, you're going to know what's wrong with them and what you can do about it. Okay? My disclosures are listed on the sheet. I don't think I have it here. And I'm going to give you the summary of my talk. It's been a long day and a half. This is all I want you to know. Okay? Chronic cough lasting greater than 8 weeks may be a symptom of an underlying cause, commonly upper airway, lower airway, GERD, or use of ACE inhibitors. Chronic cough that persists despite adequate treatment of identifiable cause is called refractory chronic cough. Or if there's no cough identified, it's called unexplained chronic cough, and it may be a separate disease. I'm going to stop. Think about that. Absorb that. That is an important new concept that we're going to talk about. RCC and UCC appears to be due to cough hypersensitivity. That is, the reason that new disease is because your cough reflex is abnormal and hypersensitive, and it has distinct clinical characteristics that you can use to identify these people, and we're going to review that. Furthermore, these patients with chronic cough, which you may not appreciate, have significant burden of physical, social, and psychological dysfunction and healthcare utilization. And what we all know is that the current framework for antitussive medications is either ineffective or have significant side effects. But at the end, we're going to talk about promising novel antitussives that are in advanced development based on recent identified cough reflex pathways. This is the message, and we're now going to go into that. Cough is just a common complaint. It's one of the most common reasons we go to the doctor. Up to now, we really haven't understood how many people have chronic cough, but we suspect in this country it's 4 to 5%. And the reason we haven't identified it because until October of 2021, the only ICD code for cough was R05. What you may realize now when you start coding is that in October of 2021, there's multiple codes for cough. R05.3 is that for chronic cough. It also has refractory chronic cough, unexplained chronic cough under R05.3. So now prospectively, we're going to be able to know how many of these patients are, and we can find them and we can evaluate. The typical patient is a woman in her 50s and just has been coughing for years and has significant burden. Now, when we talk about cough, it's divided into duration. It's the acute cough under 3 weeks, which is COVID and viruses and all that stuff. The subacute cough is going to be 3 to 8 weeks, which many times is post-viral, which is going to be neurogenic hypersensitivity, but can be inflammatory, which is why that steroid burst on week 3 works and it didn't work on week 1. But where we're going to reserve this discussion is chronic cough. Okay, and it's greater than 8 weeks. And the mantra that God bless Richard Irwin, who's the grandfather of, used to be the father of cough, now the grandfather, has in the literature for now over 30 years, the mantra of a non-smoker, no ACE inhibitor, normal chest x-ray, has either upper airway cough syndrome, lower airway disease, or GERD, or a combination of all that. And many times the cough is just silent. And that's been the mantra for these last 30 years. It's still relevant, but we're going to improve on all of that right now. Now, this slide basically tells you that cough is a problem for your patients. They're frustrated. They spent a lot of time and money going to multiple doctors, going and get a lot of therapies. They're still coughing. They're vomiting. They're urinary incontinence. And universally, when we analyze these patients, as I do in my center, is that they universally have anxiety and depression. This is just not a nuisance. So the approach to cough is, as we talked about, you'll see this slide multiple times. And what it adds is that we have upper airway cough syndrome. What we do as rhinologists, cough variant asthma and non-asthmatic eosinophilic bronchitis. We'll talk about that. There's acid and non-acid GERD. There's irritant smoke. Always looking and thinking